Hello, everyone, and thank you for joining us today. My name is Carol Warshaw. I'm the Director of the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar will be Responding to Mental Health Crisis, Program Policies that Support Trauma-Informed Responses to Emotional Distress and Crisis. Our wonderful trainers today will be Michelle Lindsay, the Model Practices Coordinator with DASH DC, Ann Kapoff, the Executive Director of New Horizons Shelter and Outreach Centers, and Sherry Larson, Lead Crisis Advocate, also with New Horizons, with some brief remarks by Cathy, who's with National Center on Domestic Violence, Trauma, and Mental Health. Before we get started, I'll go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using This Webinar System tab on the upper left-hand side of your screen. Please be aware that your screen might look a little different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your colleagues, as well as get in contact with the trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also with the center, if you have any questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You will see a lot of options. But for this session, you'll want to select all participants if you'd like to respond to a question from the trainer or to contact me anytime during the session. You should click on Angelica Medina to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, and type in where you are calling from, and then press Enter. Perfect. Thank you all very much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, you can feel free to minimize the chat box by clicking the arrow next to where it says Chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a Media Viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word Media Viewer, the same way you might if you want to hide the chat box. At the end of the webinar, you'll be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection. So feel free to call in if that's a problem for you. If you are experiencing technical difficulties and are unable to contact Angelica, you may call WebEx Tech Support to resolve any issues. That phone number, which we will also post in the chat box, is 1-866-229-3239. Again, thank you for joining us today. I'll now turn the training over to Cathy.
I just wanted to take a moment to welcome you all and to let you know this is our third webinar in our series on really thinking about how we respond to mental health crisis. And we're focusing today on program policies and practices. And each webinar that we do in this series has a different focus. So based on what you hear today, I would like to invite everyone to both join us for future webinars in the series, but also to suggest topics that would be helpful to you. So thank you very much, and I'm now going to turn this over to Michelle Lindsay, who's our first presenter today. Thank you.
I'm so honored to be speaking with you all on a webinar. It's really funny for me not to be able to see people's faces when you're doing a training or speaking. But I wanted to share some information with you about DASH. My colleague Paul, who was supposed to be with me on this webinar, is not feeling well, so I'm going to be doing it by myself. I hope you can see what's in front of you right now, and we have 2 folios that I've attached to this training, and it will help you know more about DASH because I have the PowerPoint, but I'm not going to go through every slide, as I would like to give you 2 scenarios of how we work with one, a survivor who's in distress, and then a survivor who's in crisis. And this is coming from things that we've experienced here at DASH. So let's start. So DASH stands for the District Alliance for Safe Housing, and we provide safe housing to survivors of domestic violence and sexual assault. DASH was founded in 2006 by our ED, our Executive Director, Peg Haskell, who really wanted to do housing, DV housing, differently. And one of the things that she talked a lot about was being a low-barrier voluntary services program. And with that, one of the things that was so important, the other thing to that is that at minimum, we wanted to provide safe nights. If nothing else, we wanted to provide safe nights, but we wanted to do it using a low-barrier model and voluntary services. So we offer emergency and long-term low-barrier housing. It's voluntary services based, as I said earlier, and it's different. One of the things that helped us in 2006 with really building this program is that we went to different programs all over. We went to Philadelphia, I think we went to St. Louis, we went to Phoenix. We just went around and sat with some of the other programs that had been in existence longer than we had. And we got a lot of information from each of those programs, and what we did was pull different things from those programs, and from that developed DASH and Open DASH. We are one of the largest dedicated housing providers of victims and for victims of violence in D.C., along with their children. One of the things, since we're talking about crisis and mental health, is that the thing that's really important and that works for us is that we don't ask the questions about, do you have a mental health diagnosis? Are you a substance use, do you have a substance use disorder? Because we don't want to start asking questions that would edge people out of getting housing. What we do, and we make it really clear, is that we provide housing, safe housing, and once the individual moves in, then we start working with them if they want the help and if they exhibit any kind of behavior which would jeopardize their housing, or if they're causing threat to themselves or to the community. Otherwise, we kind of let people be, and that's part of our model practice. One of them is sovereignty, you know, allowing people to make their own choices on how they want to live. So that was something that was really important to us in the beginning. So we have Cornerstone, which is our emergency and transitional safe housing. We have an empowerment project, which is our transitional to permanent housing. We have a survivor resiliency fund, which we use those dollars to help survivors stay in the community, maintain their housing, keep their jobs. So anything that's going to interfere with them maintaining their housing, we try to assist them financially so that they can stay in their housing in the community. And we have our Housing Resource Center, which is where all of our survivors come through that live in the DASH and the EP housing program. So I spoke a little bit earlier about the voluntary services. One of the things that we felt was really important is that service should be voluntary and not a condition of housing or receiving other services or assistance. So an individual can come to us who does have a mental health diagnosis, does have a substance use disorder, and they don't have to access services. The one thing that we strive for is that they meet with their advocate once a week so they can stay in touch and make sure that they're doing okay, because that's the only way for us to gauge if something different is starting to happen in their lives. So these flyers have a, I'm sorry, I keep on going through talking, I'm sorry, and not clicking through. Okay, so the PowerPoints have a lot more information than I'm going to go through, because if I went through everything, it would take me forever, and I only have a short amount of time. So these are our model practices: sovereignty, empowerment, accountability, partnership, compassion, and integrity. And we use these in everything we do and the work that we do with the survivors, and not just the survivors, with our community partners. And a lot of times, excuse me, the airplane going by. A lot of times there's a lot of push and pull between these things, and we work very hard to, in the middle, if you see, recenter ourselves when we're off balance or when a resident is off balance and she or he needs assistance in getting back on track. So this is something that's very, very important to us. So sorry, I just read the first one. It's having the freedom and responsibility to determine what is right for you and to be self-governing. Empowerment, giving voice to your own power and providing the tools to help others recognize and access their power. Accountability, being accountable to set a set of best practices and standards and keeping clear boundaries between yourself and your work. These are the practices that our advocates, all of DASH follows, but specifically our advocates, because they're working directly with the participants. Partnerships, creating and sustaining mutually cooperative and respectful relationships with the community and with the survivors that we provide services to. Compassion, having empathy for others who are affected by misfortune and working to understand and help them. Integrity, behaving consistently with the values you promote. Striving should be to know yourself and behaving authentically. And then recentering, which I think is so, so important, is finding and maintaining clarity and focus in the face of change and uncertainty, being able to think critically and respond appropriately in challenging situations. There are a few more PowerPoints, but I want to stop right here because I wanted to talk a little bit about our practices, our model practices, when working with an individual that has a mental health diagnosis or who's undiagnosed. And usually when a survivor comes in, they're not presenting as if they have a mental health diagnosis. If they're in crisis, it looks a little different the longer they stay in programs. That's what we have noticed. So I want to talk about an individual who came to us and had been here for about 6 months. This is somebody who was going through distress, not crisis. She'd been here for about 6 months. She came in, presented very well, had a job when she came in. She had 3 children. All 3 of her children had developmental needs. They had some special needs. But she seemed to be maintaining everything. She had a car. She was doing really, really well. And the longer she stayed with us, the more we began to see that she was really having a lot of stressors around being able to maintain employment and also take care of her children. And eventually, I would say about the 7th month, she lost her job. And the reason why she lost her employment was because she had to keep taking off work to attend to one of the children. So this became a stressor for her. And then as time went on, the kids really, really began to occupy a lot of her time. Now, during this time, she's meeting with her advocate. She's telling her advocate that she's feeling stressed and she needs help, but she still was able to maintain. And the advocate would meet with her and let her know, let us know what you need. I guess about towards the end of the 7th month, She came to the advocate and she said, I am so stressed out, I'm about to lose my mind, I don't know what to do, I can't do this anymore. Now, then the advocate, of course, began to ask more questions. She brought in the, at that time, our social worker to sit in with her to have a conversation to find out actually what the stress meant to her versus us trying to figure it out. So we talked with the resident, and what she said to us was that I'm having a really, really hard time. I can't keep a job. My children are all over the place. I don't know how to maintain the same level of stress that I'm having. I need some help. So as opposed to calling in our emergency program, she didn't talk about wanting to kill herself. She didn't talk about harming the children, but she did talk about how she didn't know how much longer she could continue on the path she was continuing on. So one of the things that we do when someone comes to us like that is we sit and we talk with them and find out from them exactly what their needs are, and we try to help them. We don't dictate to them what we think should happen for them. So upon speaking with her for a while, she and the advocate met one-on-one, and what she said to the advocate was, I need someone to take my kids for a couple weeks. I just need time to get my mind settled. I need to figure out where I'm going, because if I don't, I feel like I'm going to lose it. She and the advocate worked together. We were able to, and she was not from D.C., so she had family out of state. They were able to reach her family out of state. One of the fathers and the grandparents agreed that they would meet her halfway and take the kids for a couple weeks. And they took the children, and it did her a world of good. The first 3 or 4 days, she just really, really spent a lot of time with the advocate talking about what the stressors were. We were finding resources in the community for her and for the children while they were gone. And with that, we're able to connect her to services so when the kids came back, she was feeling much better. She had recentered herself, and things went really, really well. And she's still here, and she's doing really good. So that's somebody who was in distress. I guess about a year or more ago, we had a young lady who was in crisis. She came to us, and I think after a week or so of her being here, we realized that something was going on with her, but we couldn't quite put our finger on it. As the addictions counselor, she and I sat and talked, and she talked about her addiction history and that she was still actively using. Now, at DASH, you don't have to be sober to live here, but you can't use in the facility. So one of the things I talked with her about was harm reduction, and also trying to get her, to the point of, getting sober, getting treatment, and whatever that meant for her. But if she didn't want to, then we focused solely on harm reduction. I would say about 4 weeks later, she was exhibiting some behavior that it didn't really attach with drug use, so we didn't know if she had a diagnosis, a mental health diagnosis. The social worker at the time sat and spoke with her, and she revealed to her that she did have a mental health diagnosis and that she felt like things were getting out of hand, that she wasn't taking her meds because she was self-medicating with her drug use. So we tried to keep in really close contact with her, the social worker, me, and also her advocate. About 3 weeks into that, we noticed that she was staying in her unit a lot more. So we were trying to figure out what was going on with her, trying to pull her out of her unit, and periodically she would come out. But at some point, she didn't come out of her unit anymore. And so what we had to do was try to figure out how to get in her unit without making her situation worse than it was. So, the social worker managed to talk to her through the door, and she didn't sound right, and we were really, really concerned that things had gotten really bad. So what we did is that we have a mobile crisis unit, and it's called CPEP, our Comprehensive Psychiatric Emergency Program, and they come out and evaluate, and if necessary, they will take the individual with them for a 24-hour hold to see what help they need. Generally, they don't take a person unless they are harm to themselves or to others. this young lady was definitely not so much a harm to herself, but she was not taking care of herself. We ended up having to go in the unit. She had locked herself in the bathroom. The mobile crisis unit came out. They spoke with her and managed to get her out of the restroom, and it was just really, really sad. So they took her to the mobile crisis unit, and unfortunately for her, they were not able to stabilize her in 24 hours. So what they ended up doing was they ended up admitting her into a hospital, and we helped them get her transferred to mental health housing because she was not able to live in community at DASH. So we treat each individual differently. It's according to their situation and what they're able to say that they need. The only time we call the mobile crisis unit is if they are harmed. And we haven't, fortunately, had to call the mobile crisis unit that often because our advocates work very, very hard to try to connect with the individual once a week, even if it's just to check in, because that way they can tell when there are changes in behavior, changes in how they're presenting themselves, be it how they dress or how they're acting in the community. And that works for us. We try not to have a lot of rules around these things because each individual is different. And that means we would have to put everybody in this box and they follow the same rules. So we work in the gray a lot. And when we're working in the gray at DASH, then we always go back to our model practices. We always resort back to those and figure out how can I help this person using sovereignty, empowerment, accountability, partnerships, compassion, integrity. And we work very, very hard as partners to try to assist the individuals that live here. And I think I'm done, Angelica.
Greetings all. This is Ann Kapoff along with Sherry Larson here in Southwest Wisconsin at New Horizons Shelter and Outreach Centers. Let me go back here to several years ago, probably really about 8 years ago, we decided that our shelter rules were too strict. Basically, a person had 30 days to come into shelter and straighten their life around. They could not go out and have an enjoyable dinner with a couple of drinks with a friend who had been a supporter because we didn't allow them to come back in with alcohol on their breath. We basically were using power and control on them also. So we sat down with a bunch of shelter staff, myself, our executive director, and our housing advocate, and took a look at what shelter life was really like. And we knew that it was too strict and people had too short of a time to stay with us. So we began to work on a resident handbook that we developed. And everybody that first comes into shelter receives this resident handbook. They are greeted with an advocate who shows them around, presents them with a room, personal care items, and so forth. And we actually allow them to have several days to kind of relax in because who knows the last time they slept? Who knows the last time they were able to get away and shower? Who knows the last time they were able to read a magazine on their own? So we've really tried to become consumer friendly to our residents within shelter. And of course, our resident handbook starts out with a welcoming letter acknowledging to them that we know that life is difficult for them at this point. We adapted our rights and responsibilities for our shelter from the Wisconsin State Coalition Against Domestic Violence. And again, this was about back in 2008. And we set up the following, and you can read through those. Of course, you can see this here, but we said that everybody has the right to be respected, and that means clients who are staying there, staff, and our volunteers. Respectful to each other. the right to be heard. At all of our locations, and especially in shelter, we have a listing of clients' rights and responsibilities, so they know what is their ability to be able to do. They have a right to be heard by us, and they have a right to say what they want to say and what's on their mind. The self-determination. So basically, we're not there to do the work for them, but we're there to help them, to give them the options and show them things that are available to them out in our community. We wanted people to know that they had safety and privacy, and that we realized that they have their own schedules and allowed them to make their own meals for their family. Way back in the day, we had one person who was assigned to cook for the whole entire shelter. And our shelter has 26-bed facility, and so we expected one person to make a dinner meal for everybody, not knowing when they would be back, and we often ended up with a lot of wasted food and unhappy people. And so, of course, we changed it to be just as if they were living at home and able to make meals for themselves and their family at their own time, the time that fits their schedule. Okay, and then next, you have the right to be supported as your role as a parent. Again, we were so strict in expecting that parents kept their children by their side 24 hours a day, 7 days a week, and this was even if the children were teenagers. We expected moms to know where their kids were at all time and to constantly have an eye on them. We've changed that because now, of course, we know that a child who is 7 years old might be as mature as a child who is 15 years old and being able to take care of themselves, and that sometimes with cognitive delays, that type of thing, an older child might need mom to be closer to them. We also encourage persons who come into shelter letting us know that if they have a warrant out for them, that it's okay with us, and we'll hook them up with our legal advocate to help them work through that and how things can be handled and so forth, again, so that it's better for them. We want, of course, everybody to live without the threat of violence. So we are basically a no-hit zone. We don't allow abuse within our shelter program. We have a youth and family advocate who helps work with a non-offending parent to help them discover better ways of discipline that are healthy and safety for their children and them. Our big one is the right to a healthy and sober and drug-free environment. Again, because we're finding that persons utilizing our shelter have been so controlled by their perpetrators, and many are using drugs or alcohol to cope as a self-medication, but yet we knew that we couldn't have this within the shelter because we had persons who are recovering or trying to sober themselves up and work on being free from drug and alcohol use. And so basically one of our real rules is to we can't have drugs or alcohol on site, so inside of our shelter or in our property. Now, if a person wants to utilize outside of shelter, let's say they want to go out for dinner with a family member and they have a couple of drinks and they come back with their alcohol on their breath, that is completely up to them as long as they are able to take care of themselves and their children. We're not going to say that they can't do that. Again, we encourage everybody to keep shelter clean, so to pick up after themselves just like they would at home. Another big thing is we ask people to keep confidentiality. So, not sharing the names of other persons staying within shelter and so forth. We want persons to develop their own plans and their own work. They have the right to reside in a program that works for them. So, safety planning and goals, that type of thing, and working with their advocates. We encourage them to do that so that while they're in shelter, they are utilizing every service that we have made possible for them. Basically, our very strict rules are if a person brings alcohol or illegal drugs into shelter, they'll be asked to leave. If they act in a manner that jeopardizes the safety of others or is disrespectful, so bullying, intimidation, abuse, physical abuse, verbal abuse, we'll ask them to leave, and blatantly breaking another person's confidentiality. If they've done this on purpose and we discover that, we can ask them to leave. We try to work on a warning system with persons if it's not one of these other three happening there, so that we're verbally letting them know what's going on, what we've discovered, and we try to help them work through that before we ask a person to leave. Next, I'm going to pass this on over to Sherry Larson, who is our lead crisis advocate. So she does direct work with our persons staying in shelter. So here's Sherry.
Well, good afternoon. Bonjour. Just going to go over a couple of the general shelter information that we hand out to residents as they move in. We obviously tell them about the safety system and that how we work with law enforcement and the fire department, that they need to come in. If our alarm system goes off, we have a definite fire process that we meet outside. Everybody's informed what that process is. We all know and understand that some folks entering shelter may be having an outstanding warrant, and that we have a legal advocate, that we can assist. Many times those warrants have gone away because we've encouraged them to write a letter to the judge, letting them know what's been going on in their situation. Sometimes it's an unpaid fine. They let the judge know that they're staying with us and trying to work on a new life. I'd say majority of the time those warrants have been squashed. Visits. We cannot let family or friends come into shelter, but if they need to meet with somebody, they can utilize our other office, which is our outreach office, or if they need to meet with somebody like law enforcement or social services, they can meet outside of the shelter for that. We try to encourage them reconnections to supportive people in their lives, and encourage them to, rekindle those relationships, and hopefully those people will be a support system to them. We have a phone that residents can use that rings out. You can dial out on it, but it doesn't have any incoming calls. If they need to hear from somebody, they can sign a release with staff, and staff will take those messages on the crisis line. We also want to make sure that when we are working with clients that to have those conversations with residents. Sometimes we have family members that call concerned about their safety, and our usual thing is, I cannot confirm or deny. I can do is take a message and put it on our message board. We do have parking for our vehicle that's behind our shelter, so it's not on the main street, and that can help conceal. We do have a sign-in, sign-out sheet that we ask all residents to sign if they're leaving for the day. So if we do have a fire or an emergency that we need to evacuate the house, we know who's all in shelter, and we also ask them to sign that once they come back in. They don't have to give us many details. It's just more or less for a head count for safety. There's this one on here that's called discretionary nights. We have actually changed that. It is no longer, we don't have the discretionary nights anymore. We went to a informed out process, and most recently we have kind of changed that again. Oh, we went to an approved out process, and now we're at the informed out process, because the approved out still kind of gave us control and as staff, so we changed it to an informed out process where they just need to let us know if they're not going to be coming back. So one, we can do some safety planning, and two, we can have that conversation that if things don't go well, wherever it is you're going to go stay tonight, away from shelter, that you can always return no matter what time of the day it is. So that has been kind of changed as well. We also let them know, due to situations, whether we have a larger family coming in or somebody with a definite disability, that we may have to ask them to change rooms. Of course, we try not to do that as much as possible, but of course, you know, we have to always be looking at who needs safety. Unfortunately, we can't do a lot about stolen valuables or money. We do provide a locker, and we do give them locker keys, but of course, theft still happens. Medications, they need, if medications are stolen, they need to contact law enforcement, file a police report. Of course, we cannot confirm or deny if that other resident who may have stolen those medications are in our house. Law enforcement understands that. We will not give that information. If they leave shelter in the middle of the night and not tell us, or are asked to leave shelter because of some of those violations, we still encourage them and let them know that, you know, they can leave their belongings here. We cannot secure it, but they do have 2 weeks to come back and pick those items up. And so they don't have to try and haul all their worldly possessions down the road with them. We do have a movie rule with the, you know, because we have children, so pretty much we do not really even allow adult viewing, only movies in shelter, but definitely when children are up and watching TV, we do ask that they, you know, respect what little eyes are watching. Food and shelter, we do ask that, you know, they can supply their own food. We get a lot of donations, and we have a small grant that will assist with some costs like milk, bread, eggs, meats, and they know when those groceries are brought in, and then they are for everybody. We do have, like Ann talked about, different lifetimes. So some people are working like the 3rd shift, and they're going to come in and eat when they get back, so just be knowledgeable about that. And then they do clean up and cook for themselves and clean up for themselves. Every now and then we do have some folks that love to cook for the masses, and we'll cook for everybody in the house. Our general policy on that is what you cook for your family, once you have fed your family and then it goes into the refrigerator as a leftover, it is for anybody. And that we don't allow marking of food, because if a new resident were to come in and we tell them that anything in the fridges can be eaten, it gets a little confusing because everything has somebody's name on it. So we just say that you can't mark it. And then, of course, anybody, like for the Thanksgiving holiday coming up, we have a great cook from the community that's going to come in and cook for all of the residents that are currently staying there. We also provide for culturally specific food or a dietary need, or for a medical reason, and we put that in a different fridge that staff has access to, so that's always available to them. And then checkout, we just ask that they check in with staff, let us know so that they are leaving, and ask that they clean up their bed and their bedrooms as much as possible, and then make sure that they take all of their things away from the shelter. If they're not able to, like I said, they can put them out on the porch. But that way we're not saving a bed for somebody that's not going to be returning. Usually we have a 48-hour, if we haven't seen somebody or heard from them in 48 hours, then we will depart them. And that's it for us.
I think one thing we'll probably mention quickly, too, is all of our advocates have been through trauma-informed care training and motivational interviewing, so that we are consistently putting the client, the resident of shelter, their needs first, and remembering that each of them is in there for a different a different reason. And so we believe that we've really become less strict within shelter. Sometimes that might be a little bit more of a thing, but not too bad.
Great.
Okay,
thanks,
so we'll...
Go ahead.
Oh, sorry. We can talk a little bit about distress and crisis in shelter, like how do we deal with crises in shelter. Sherry, maybe you can give us an example with residents. How do we handle if residents have a crisis in shelter?
Well, I encourage my staff, which are all the crisis advocates that are there on 3 different shifts, to try and have a conversation. Give them the time, the opportunity, but also give them the time and the opportunity to come back and have that conversation. So sometimes we'll say, do you need 15 minutes? You're a little upset. How about taking 15 minutes, and then let's have a conversation, because I'm worried about you. I'm concerned. I'm hearing this, or I've seen you, get really upset. So we really try to encourage staff to let them know that we're here if you want to talk to us, and that we see that you are in distress or definitely in a crisis, and how is it that we can help with that.
Then it looks like somebody has a question about the trauma-informed training. So basically, trauma-informed care is a huge thing around the state of Wisconsin and southern Minnesota, and it's the learning how to talk with persons and how to get residents and clients of abuse to open up and share about their life and to not re-victimize them. So basically, saying instead of what happened to you, or saying, what did you do, why did this happen, we say, tell me what happened to you, who did this to you, those types of questions. So they're kind of those open-end questions so that the residents know that we are caring about what has actually happened to them, because nothing, of course, as we all know, nothing they did caused the abuse to happen.
Great. Thanks, Ann and Sherry. So at this time, if anybody has any questions, we have quite a bit of time for questions. So if anyone has any other questions for Ann, Sherry, or Michelle, you can chat them into the chat box, and we can have a little bit of Q&A time. So I'll wait a couple minutes to see if folks have questions, and then we can wrap up. Okay, so it looks like we have someone coming in saying they would like to know what degree is needed to become an advocate for victims. I'm going to unmute Ann and Sherry and Michelle, whoever wants to jump in.
Okay. Well, at DASH, you don't need a degree, but one of the things that all of our advocates, and in D.C. in general, the DV advocates have to go through a 40-hour training through our the Coalition on Domestic Violence in D.C. So that's one of the things that's required.
And here in Wisconsin, you do not need a degree either. We do have an in-house training, and the state coalition also offers 8-hour training. Our in-house training is about 20 hours.
Great. So another question we had come up is, have any of these organizations asked survivors directly to share feedback on policies and practices?
Definitely. We have client surveys. We usually ask for them, these shelter residents, to fill out a survey. Usually once they them in the shelter if they've been there for a little bit, and then, of course, we want them to do that again when we know that they're about to exit shelter. And on that, one of those questions on there is anything you would do to improve our services. And then each staff person that they may utilize, whether it's housing, legal, youth and family, resource, they all have a as well. So we are always looking for client input and definitely those services.
And here, I'm sorry.
That's okay. If you don't mind, Michelle, I'll go quickly. Just for example, here on a survey that we're looking recently at, and it's from a shelter survey, one of our clients said that they would like more insight in terms of resident-to-resident violent interactions and conflicts. That's something we'll be addressing as to how we can best give information to our residents as to how, when it's that one-on-one conflict, how they can work to resolve some of those things themselves.
Great. Michelle, were you going to say something?
Yes. I was going to say that here at DASH we do care conferences, and we do them when the survivor moves in. We do it at a 6-month period, a year period, 18 months, and then maybe like 2 months before they leave. Our housing program is for up to 24 months. And in that care conference, we ask them questions about the services that they're receiving. Are they happy? Are their needs being met? And what we're trying to get at is whether or not the advocates are actually using the DASH model practices. So we'll ask them questions like, do you feel, more empowered now than you did when you first moved in? Ask them questions that get to wherever they're going, and the advocate knows kind of what they're working on and where they are in their lives at the time. So we try to get questions like that answered because we want to make sure that we're providing the highest level of services, not just to one person, but to all of the residents on an individual basis, because everybody's need is different.
Great, thanks, Michelle. So another question that we had was, how do you handle residents who bully others in the community?
Well, at DASH, we don't have a lot of rules, and one of our rules is that we don't condone violence, any kind of physical, mental, emotional, any kind of violence. So what we do is we try to work with the individual who's actually doing the bullying, while at the same time working with the individual who said that they've been bullied to try to get at what's really happening. A lot of times for us, what happens is that the survivors will form relationships as friends, and someone gets mad at the other one and they end up in an argument, and so it becomes this kind of relational thing that's going on. But what we do is the program director and the advocate sits with the individuals separately and then try to bring them together so they can talk about what's going on. Now, if we notice that there is one person that it really is doing the bullying, we try to work with that individual, but we also check with the person who's being bullied to ask them, do they feel safe? And if they say they don't feel safe, then we will work with the person who is causing the harm to that person emotionally, mentally, and try to help them find alternative housing.
Thanks, Michelle. This is Cathy. So I wanted to just take a moment to kind of think through some of the things that you all have been talking about in terms of model policies and practices to really, on the front end, to be preventive, to really provide the space and supports that folks need when they're in crisis and when they're experiencing distress. And that in that, one of the things I wondered about is You know, when we think about being trauma-informed and that survivor's voice really does drive all of the things that happen in the relationship, in the service relationship, right, then I wonder about, do folks, and this is for any of the panelists, talk with survivors on the front end about when you're in distress, is there something, what does that look like for you? What does that feel like for you? And is there something that's helpful? And do you all have that kind of a practice or policy in place?
Well, at DASH we do. When we do our intake, our residents come to us from our Housing Resource Center, so we don't have anything to do with who we're getting. We just know that we're getting a survivor. So when that survivor comes in and the advocate's meeting with them, going over, you know, DASH and showing them around, we have an adult intake form. And what we do is then ask them all those questions about, do you need help with anything that's going on in your life right now? When you're in crisis, who should we call? What does your crisis look like? When do we know when to call someone? Will you reach out to us, or do we need to reach out to you? We have those questions on our intake form for the moms and if we have a male survivor in at the time, and their children, because it may not be just the survivor, the original survivor. It may be also the secondary survivor, which is the child who's witnessed the abuse. So it just depends on who it is, but we definitely ask those kinds of questions.
I think the same thing here is we really try to see what works for them, what has worked for them in the past, who is part of their support team. There is a clinician, their doctor, a relative, a pastor, whoever is part of that team. We want, you know, to, one, be part of that team, but give us somebody that you would like us to call when you are expressing whatever it is. We, too, have a mobile crisis. We tend not to call it very much. We do offer it as a resource for them, and they more or less let us know if that's something that they're willing to do. Some of them have just come out and just said, hey, I just feel like I'm probably going to be safer in the hospital, and we make that happen.
Yeah.
Thank you. And I wondered, too, about when folks are in distress and staff are feeling or thinking that it's related to a mental health condition, how comfortable are staff in having those kinds of conversations? Can you speak to that a little bit?
We have a training here that we also send staff to. I think it's called a mental health first aid training, and they kind of get a little a training in a few different examples, but more or less, like I said, we encourage staff to have those conversations. Some conversations are harder for others, but we want them to reach out, have that conversation with the client, have the client bring that as part of their safety plan. What should we do? Who should we contact? And who is all part of that plan? Obviously, if to my knowledge, we've only had where somebody has tried to harm themselves in shelter, and of course we had to reach out and make an appropriate phone call, and then also make other phone calls regarding the children that were still at our house. We're a very, I'd say, gray-thinking agency. We can't afford to be a black and white agency. It can't be like there's a policy scenario. But we do a lot of team. We do team meetings and staff it and try and come up with an appropriate response for that client. Everybody's so different.
I'm sorry. Just wanted to comment really quick. Some of the training, the crisis training, happens at the 40-hour training for the app for the DV advocates, but we also once a month have in-house training. So it's an 8-hour training every month, and we bring in outside community partners to come in and offer trainings around crisis, around substance use disorder, around HIV, different things like that. I think the thing that I know I've run into is that sometimes it's not the resident's crisis, it's actually the advocate's crisis. And I say that to say that all advocates are not comfortable with all walks of mental health, even if they've had training or mental illness. And so it depends on what's going on with the resident and who the advocate is. The good thing that I think that we do here is that we let the advocates know if you feel uncomfortable, get someone to help you, that you don't have to sit through this alone. So I think it's really important that they do have the space because different people handle different things, just as the survivors do, our advocates do. I think we all do. So.
Yeah, thank you for that.
Mm-hmm.
I really appreciate it because I think it does open up the conversation around there is no one way to respond to any one particular thing. It's what works for me in the moment and who feels supported in the moment. And how do we best work this out where I still have my relationships intact and I still feel that I can trust the staff and trust the space that I'm in.
I totally agree.
Great. So we have a couple more questions. There were two that were relatively similar. One around if your services or if you know of some similar services that are available for undocumented individuals. And then on a related note, how do you address crisis counseling and intakes with non-English speakers and folks without Social Security numbers?
No, we don't ask for any of that information. They don't have to prove their identity. They can come in with an alias. We don't ask for a driver's license, a Social Security number, or documentation. So I make that very clear when I can hear that hesitation on the crisis line when they're calling in for those services. And sometimes I've even made up an alias name for them. And I'm like, just show up at the door and tell me you're Anna Smith, and we'll go from there. So we don't require that. State of Wisconsin does not require any of that identifying information.
Same here at DASH. It doesn't matter whether they're documented or undocumented. We accept survivors from anywhere across the country. If we have space, we'll take them. And we connect them with providers in the community that can help them, as well as interpreter services. Because we do have people, sometimes we don't speak their language. We had someone recently, we couldn't even figure out what the language was. So we had to keep making phone calls till we figured it out. So, yeah, we use interpreter services quite a bit.
And we do, too. We have some staff that speak Hmong and Spanish. And then if it's above, that's the majority of our population. And then if we need assistance for another language, we have a language line that we utilize, and that's available 24 hours a day.
Great, thank you. So a few more questions. Are advocates trained to recognize and support women who are experiencing anxiety or having trauma responses? Do you provide women's groups? Are there supports for women who may have extremely exhausted, sleep deprived, and therefore having difficulties functioning?
Yes, we do provide those groups. And like I said, all of our services are free and offered to everybody. It doesn't mean that they have to utilize them to receive our services. Sometimes down the line, after they've kind of built a relationship with us, they will seek out those services. We do have a trauma specialist on staff that does one-on-one and group work. And we have groups that are in shelters, and we have groups that are in the community as well.
And we operate pretty much the same. We have in-house groups. Women are not required to come. They don't have to if they don't want to. We try not to be involved in facilitating any of those groups, any of the advocates or us. We want the women, the survivors, to feel safe and talk about whatever they want to talk about and know that it's not going to get back to us or we won't share it with our colleagues because we don't know anything about it.
That's with our trauma specialist, doesn't share any of the information with any of our staff as well.
Great, thanks everyone. So that was actually going to be our last question. I had a couple of questions come up around the slides. I sent them in the chat. However, if you didn't get them, we will be following up with folks in a follow-up email. Also, if you had any other direct questions that we weren't able to get to, feel free to email me, and we can see about getting those questions answered for you or referring you to the correct person. At this time, I'm just going to forward it over to Carol to wrap us up, and thanks everyone for joining today.
Thanks, Angelica. So I'd like to thank Cathy, Michelle, Ann, and Sherry for such an exceptional webinar today. Thank you to Caption Colorado for providing today's captioning, and thank you to Angelica Medina for making the webinar run so smoothly. Last but not least, thank you all for spending your time with the center. Within the next week, we'll send you all a follow-up email with a link to the recording of today's webinar in addition to the slides and handouts referenced, all of which will be available on our website. You will also receive a certificate of attendance for your time today. At the end of the webinar, you'll be taken to a very brief evaluation. If you could please take a moment to let us know what was useful and what could have been better, it would really be appreciated. Thanks again, and we hope you all have a great afternoon and holidays.